On behalf of the MD-Run Collaborative, my name is Irina Yudin, and I'd like to introduce Module 7, the lumbar puncture. Just like previous tutorials, we will give a quick definition of the procedure and discuss in more details indications for these procedures, safety considerations, intra- and post-procedure care and monitoring, as well as complications that can result from these interventions. Our hope is that the educations from this tutorial will prepare you to work more competently and collaboratively with your physician colleagues to provide safest care for your patients. The lumbar puncture or spinal tap is performed to obtain a cerebrospinal fluid sample, measure CSF pressure, drain CSF, or access the subarachnoid space for infusion of medications or contrast agents, similar to the thoracentesis and paracentesis that can be done for diagnostic or therapeutic purposes. The most common purpose for a lumbar puncture is to collect cerebrospinal fluid in cases of suspected meningitis, since there is no other reliable tool for which this life-threatening but highly treatable condition can be excluded. Okay, indications to do LP include suspicious of CNS infection, just as mentioned, clinical presentation suggestive of subarachnoid hemorrhage with a negative CT, suspected Guillain-Barré syndrome, suspected multiple sclerosis, intrathecal administration of medications, imaging procedures requiring contrast agents, measuring of CSF pressures and drainage of CSF fluid in cases of hydrocephalus, pseudotumor cerebri, and CSF fistula. Contraindications for the LP include increased ICP due to the mass or idiopathic conditions. A lumbar puncture in the presence of increased ICP may cause uncal herniation. The exception to this would be doing it for therapeutic purposes, thereby reducing circulating CSF to reduce pressure. Other contraindications are superficial skin infection at the insertion site, coagulopathies of course, hypertension associated with bradycardia and altered mental status, which we know is indicative of Cushing reflex, and may indicate brain herniation. Of note, a brain CT is advocated by some prior to an LP, especially in the following situations: patient over the age of 65, reduced Glasgow Coma Scale, recent history of seizures, focal neurological signs. It is important to note that normal CSF values are an opening pressures between 50 and 200 millimeters of mercury, with clear and colorless appearance, a white count of less than 5, glucose 60 to 70% of serum glucose, protein levels between 15 to 45 with negative cultures. Preparing for the LP is simple. Get the procedure cart. The kit will be in the side arm. Lidocaine is packaged within the kit, so you won't need to pull it out of the Pyxis. Make sure you have extra towels, pillows, and bedside table to support your patient's position. You may need to consider asking your care partner to assist you in holding the patient position as well. Let's review our standards of procedural safety and complete your pre-procedure care. Consider past medical history and what may place your patient at increased risk, particularly scoliosis, lumbar surgery with fusions, and increased ICP. Assess and record your patient's baseline neurological status. Do they have a coagulopathy? Check for allergies. Be sure to check in with your patients and family to explain the procedure and see if they have any further questions. Check to make sure that the proceduralist is credentialed to perform the intervention. Check new innovations. Finally, be sure the consent is signed and initiate and document the timeout before the procedure gets underway. Once again, let's review the intra-procedural care guidelines to support sterility and safety. Start by double-checking yourself to make sure you have everything you need for the procedure in the room and the procedure cart is close at hand. Wash hands for a minimum of 15 seconds, put on a cap, mask, and gloves. Maintain sterile procedure with all assists. If you're holding the patient to assist, be sure to avoid getting near the sterile drape. Reevaluate your ability to support a patient's position and assist in the procedure. Get additional help from the care partner or intern to make sure the patient is well supported to maximize a successful procedure. Also, do a quick assessment of the patient's vital signs while positioned in the procedure and evaluate their ability to tolerate the position for the duration of the procedure. Communicate any concerns or suggestions to the proceduralists before getting started. Offer reassurance to the patient throughout the process. Keep an eye on the patient's vital signs, mental status, hemodynamics during the procedure. Communicate any changes from the baseline during the procedure. Patients will receive lidocaine for local anesthesia. Administer additional sedation per order or as indicated during the procedure to facilitate comfort and cooperation. Once the needle is in place, communicate with the patient and encourage them to breathe normally, as many patients hold their breath during the procedure. Provide sterile assists when necessary. More often than not, there are two physicians working together to perform the procedure, and it's not necessary. Immediate post-procedure care includes applying a dry, sterile, occlusive dressing to the puncture site, assisting the patient to supine flat position if tolerable, and monitoring the neurological, respiratory, and cardiovascular status. You will want to monitor vital signs and neurological evaluations Q15 minutes for the first hour, then 30 minutes for another hour. And if the patient remains in ICU, your vital signs after that will be once an hour. Otherwise, every 4 hours is adequate if patient goes to the floor. Keep an eye on the puncture site. Make sure the dressing remains dry, clean, and intact. Instruct the patient to remain flat for 1 to 4 hours following the procedure. May turn from side to side to alleviate pressure points. Ensure adequate oral and IV hydration post-procedure. Complications that occur as a result of a lumbar puncture can include herniation. This can appear as a pupillary changes, bradycardia, with a rise in blood pressure and associated with the changes in mental status. Other complications include excessive drainage or bleeding at the insertion site, cranial neuropathy, spinal or paraspinal abscess, implantation of the epidermal tumors, vasovagal syncope, seizures, pneumocephalus, and headaches. This concludes the tutorial on lumbar puncture. We have just one more to go. Hang in there, and thanks for listening.